All right, let's go ahead and get started. Hello, everyone. My name is Cynthia Klein, and on behalf of the Take Heart Initiative, I'd like to welcome you to today's discussion. The topic for today's affinity group is operational adjustments while resuming your in-person cardiac rehabilitation program. We are really pleased today to have joining us Dr. Hisham Scally. We will also be hearing from Steve Hines, as well as several of your colleagues participating in Take Heart. Just a quick update as we begin today. The Take Heart team is continuing to plan for resuming activities, so the training and the rest of the implementation activities. We are keeping in contact with hospitals in both the partner hospitals and learning community hospital groups. If you are in the partner hospital group, please know that we'll be reaching out again in August just to kind of see how you're doing, what activities your hospitals are taking part in, also kind of seeing your readiness to continue with the Take Heart initiative. So really just checking at that point. If you are not part of Take Heart, we welcome you here today to today's discussion. Please know that we are continuing to recruit, and events are open to anyone who wants to join the learning community. So the link here at the URL Take Heart /join Take Heart. So it's available to join the learning community there. Also there you can see a website address if you have any questions about the program, want to contact us for any reason. We please do encourage you to go ahead and do so. So with those announcements, again, welcome everyone. Really appreciate you joining us today. I'm going to pass it over to Steve Hines, who will be kicking us off for the discussion on the next slide. Thanks, Hisham, and thanks, Steve.
All right, thank you, Cynthia, and we do want to welcome you to what we're excited about today, which is a discussion about the adjustments that you're making as you resume your on-site operations. And just to give a little bit of background on how we'd like these events to work, we really want everyone to learn, and if you were not expecting to learn, you wouldn't be here, but we also want to encourage everyone to share, because in the chat function, we give you an opportunity to raise questions, mention resources, respond to other people, and the more that you contribute to that, the more valuable the event will be for yourself and for everyone else. And then we really want this to be a supportive environment, and we've really been excited and pleased by the support that we've seen in the chat comments with the panelists, because we know it's a challenging time for everyone, and we think that these events can provide not just information that will be valuable to you, but also a forum for you to give and receive support from your peers, and that's a very important thing. So we want to continue that process today, focusing on operational adjustments that you're making, and we're going to be using the chat and polling features so that you can dialogue with the participants and learn from each other. So just to introduce the experts and panelists that we have on today's event, as Cynthia said, Dr. Hisham Scally is leading the event today, and we want to thank him for his facilitation of the chat that's going to begin in just a second. We really are happy with the peers that you're going to be learning with and having the chance to interact with today. Those include Anna Esquerra from the South Texas Health System Heart in McAllen, Texas. Jean Marie Gallagher from Suburban Hospital, which is part of Johns Hopkins Medicine in Bethesda, Maryland. From Heidi Hagelin, who's at Essentia Health in Duluth, Minnesota. From Marianne Compton, who is at UNC Health in Chapel Hill, North Carolina. And then from Nick Eimers-Mosier, who's at CCCC Comanche County Hospital Memorial Health in Lawton, Oklahoma. So we're excited about these panelists, and we really are pleased by the range of experiences that you're going to be learning from. You can see geographically that we have people spread across the country. There are hospitals represented here that are in urban, suburban, and semi-rural settings, with people coming from 100 miles away or more to attend cardiac rehab. The programs can vary in size from very modest size to larger facilities, And then we recognize that there are varying levels of COVID impact that you're experiencing right now, and we particularly want to extend our best wishes to those of you that are in parts of the country that are really seeing increases in rates. So those are the ranges of people that we'll be hearing from today, and we want to, before we get into the discussion further, just remind you of a couple things related to the chat function. To participate in the chat function, you need to open the chat box. That's the icon that's pointed to there that looks like the little, cartoony commenting bubble. And then please, when you get started, set the to field to say all participants. That's the option that we really would like you to pick, because if you just pick all attendees, then the panelists don't see your comments. If you pick all panelists, then your peers don't see your comments. But if you pick all participants, then we all see your comments, and that will make it a lot easier to respond to you or to learn from the things that you have to say. There's also a polling function that we want to introduce right now, because we think it's interesting to see what you and your peers are thinking, where your programs are at right now. So we'd like to introduce this first question, which you should be able to respond to to the right of your screen. You'll see the polling question there. And we'd just like you to share what best describes the current status of your hospital's cardiac rehabilitation program. So if you can click an option there, and then we'll close out the poll in just a second here, and it takes a few seconds, and then you'll be able to see the results. So tell us where your program is at, from completely shut down to patient visits are canceled, but you're providing mostly online support, to limited support, to reasonably normal operations. So we can close out that poll now, and Teresa, when it comes up, we'll look at the polling responses so that you can see what your program is before we move on to the second question. All right, so 70% are reasonably normal operations, and it's fascinating as we've done these events to see the changes over time. So we're delighted to hear that, and we're hopeful that you're able to sustain that despite the surges that we're seeing in some areas. As we move to the second question now, we've changed this up a bit from the past because there's some issues with surges right now. So we're just curious, how likely is it that your program may need to reduce your level of on-site operations again at some point before the end of the year due to a resurgence of COVID-19 in your area? And we obviously know that none of us can predict exactly what's going to happen, but we are interested in whether you think that's very likely or somewhat likely or not real likely or not likely at all. So if you can pick your response there, then we will go ahead and close out that poll and take a look at those responses just to see where you're at. And this is very useful to know for us as we also continue to plan with respect to resuming the first learning cohort. So maybe a little over 50%, almost 60% think that there's some chance or a high chance that you're going to have to curtail your on-site activities again. And really, very few of you are close to 100% certain that that's not going to happen. And in the current environment, not being able to say anything for sure, I think, is true in most places. All right, let's do one more question before we dive into the conversation. And that is, as we think about the topic for today and operational challenges, we wanted to see the areas that you think are your biggest challenges, just so that we may be able to devote some extra time to those things as we continue our conversation today. So you get a chance to pick two. If you can only decide on one, that's perfectly fine. I don't know it'll let you pick three, but of those options that are listed there, which would you say are your biggest challenges? encouraging patients to resume, expanding your available capacity, dealing with staffing shortages, financial problems for your program or your parent organization, or obtaining, patient compliance with the changes that you're making, or something else related to operations or to safety. So if you can pick your final two, deliver your final answer, and then Teresa, we can close out the poll and take a look at the results from this question. All right, so we'll see here in just a second. Capacity is a big issue. And it seems like, many of you are dealing with the challenge of encouraging and giving guidance to patients about when it's appropriate for them to be returning to your facility. Financial problems and obtaining patient compliance are certainly substantive issues as well. So, and it's kind of good to see that staffing shortages are certainly an issue, but not a large issue in many of your facilities. So all of those are useful pieces of information for our panelists to know as we go into the conversation. And at this point, I'm going to turn it over to Hisham to kind of overview what we're doing and then lead our panel discussion.
Thank you, Steve. Those questions were very informative, and thank you for introducing our speakers. I welcome everyone. We have over 120 people already present on our webinar right now, and I welcome every single one of you guys. We've had over 100 people in all of our previous action groups meetings, and actually that's very encouraging, and that just speaks to your level of engagement and interest in these programs, and we hope these are as useful and instructive to all of you. I certainly get to learn a lot of things every time I am on one of these conferences and calls. So today we're going to be talking about the operational adjustments across the cardiac rehab patient visit cycles. So really, how have we managed our programs at different levels, whether how we changed our capacities, how we changed our schedules, and how often we see patients, how have we changed the patient experience on site, what have we done to continue to be engaged with the patient, and how we continue to support them, how are we supporting our staff as well, and how are we adjusting our different schedules and well-being as well. So it's detailed on this slide, but I think the next discussion is going to be more informative. So I'd like to start with the first topic, which is the unit capacity adjustments, and I'd like to thank our peer experts invited on our panels. The first question that I have here is how has your unit capacity changed, and is this affecting which patients you are scheduling? And Jean Marie Gallagher from Bethesda, Maryland, actually welcome to this webinar. And what would you like to say to us about this? How have you changed your capacity so far?
So basically, I sat down with my medical director and talked about who do we want to bring in first, as far as, because we are only going to have about 5 to 7 patients at a time, where we used to have 25 patients in the room. So we discussed doing the lower risk patients, both with cardiac risk, looking at ejection fractions, and also with the COVID risk and the comorbidities. And we kind of tailored it to the people that were in the program that had done 12 sessions or less, and also people that had had events in the last 3 months that haven't had the opportunity to do any cardiac rehab at all. And we started with that. Good.
So that's interesting. And that makes a lot of sense to invite the low-risk patients, both from a cardiac standpoint and also from a COVID standpoint. Yeah, certainly inviting the low-risk patients from a cardiac standpoint actually is interesting, because if they were to get, hopefully not, but if they were to get infected during their commute or within the program or in between, they might have a better chance of making it out of there, actually. So I think that's reasonable. Other people have looked at whether inviting the highest risk patients from a cardiac standpoint, because they're the ones who derive the most benefits from cardiac rehab, would be best served. But it's certainly a question there and very debatable.
We also started with the heart attack and the open heart surgery. So we started with those two diagnoses as well.
Excellent. Yeah. And as you know, as you very well know, actually, those are some of the people who would derive the most benefits from attending cardiac rehab and attending it rather early than later. Yeah. So that's very, it makes a lot of sense. Marianne Compton from Chapel Hill, so another further south from Maryland. So how have you changed your program?
Yeah, so we opened after being closed for 11 weeks. And
Wow.
During those 11 weeks, we had kept in touch with our patients who had been with us before our closure. And so we decided to start back with those patients that were willing to come back, and quite a few of them were. I mean, and that was a tribute to our staff. They were comfortable, confident, and that our staff would take care of them. Our staff was comfortable with doing it this way because they were already familiar with the patients, and they knew that the patients knew our program, and so they wouldn't have to start from scratch with these patients and could really focus on implementing the changes that we had in place with our social distancing, keeping patients further apart, giving them the masks when they came in, all the screening. And that worked really well for us. And then by starting with those patients and then adding in the patients that had been canceled and then getting to our new referrals. So that's worked well for us.
Good. Yeah, and that's a very clever way to do it as well, because the patients you already know, already trust you, already trust your staff. And as you said, it's a credit to your staff because these patients also have been hunkered down at home for 10 to 12 weeks or so. And so it speaks to their confidence in your program and other cardiac rehab programs to come out of their homes and come in to get rehabilitated again into exercise and educated and so on. So I think that's very important. It also gives your staff and your cardiac rehab team to see faces they've known already, they have met before, and that they know that they will have an impact. And then you transitioned, as you said, to people who were canceled and did not get to attend the initial classes because they happened right during the confinement period, mm-hmm. Then the ones who were just more recently referred. And I suppose, like every other program, you still run in through your list of all the patients you have to catch up with.
That's correct. We have quite a few.
Okay, good. So has that led to a change in the way and you are scheduling your visits, and how often are you getting patients to come? How many classes have you had? How often have your classes? That's the next topic that we have. And let's hear from Heidi Hagelin from Duluth, Minnesota.
Hi. So what we had to do here is we reopened in stages, and we based the frequency of the patients' appointments based on their complications if they were to contract the COVID-19 virus. So at first, patients were allowed to come between one time a week to once every other week. And as we're reopening further, we're allowing those patients at the lowest risk of complications for COVID to come twice a week, and then the ones that are higher risk to come at once a week. We've also added the number of phase 2 classes we offer a day. At this time, only one extra class.
Okay. Yeah, so again, another theme that we're hearing here is really balancing the risk of getting COVID and what complications you might have from getting infected versus the benefits of attending cardiac rehab. And so you chose, you've elected to actually select the people who are the least, where their risk of COVID actually would be the lowest. And so to start with that, and then enrich the classes and enrich the program and allow them to come more often as their risk is lower. So that makes a lot of sense again. Nick from Lawton, Oklahoma, how you doing?
Pretty good. Thanks for having me.
So how have you changed your program? I suppose you were closed also during the initial period, and what have you done so far, and how are you dealing with the recent numbers?
Uh, so in regards to the adjusting the frequency, so we were closed for a month in its entirety, and June 1st is when our governor really gave that okay for the vulnerable population to kind of come from the stay-at-home orders. So June 1st is when we reopened, and in our, we're a semi-rural institution, meaning that we have lots and lots of rural census, and our census was quite large prior, and almost every one of them were so eager to come back. A lot of these critical access hospitals refer to us. And with that being said, we kind of had to change that schedule to be able to accommodate as many patients safely. So what we did is we added a phase 2 class in the morning and then a phase 2 in the evening. So we have 8 classes a day now. And the way that's really kind of helped is we're able to see more patients in a shorter amount of time, because we did have to take a day off of the schedule as well to accommodate for staffing. But above that, we had to stop the phase 2, the maintenance program. And we're also not really seeing many of our supervised exercise therapy patients at this point either.
Okay. Yeah, so again, a lot of adjustment there in terms of what classes you are doing and which one you have canceled and so on. So let's talk about more operational question. And so what have you, let's start with Anna Lisa Esquera in Texas. And Anna, welcome to this webinar. And could you please tell us what adjustments you have made to the operations of having the patients coming to the rehab? So your intake process, your screening, and what have you learned so far?
Currently at this time, we see a recent increase in COVID cases. So it is really very challenging for our facility. We are a newly launched facility this month. We basically are thankful that we were able to launch the program, given all these circumstances and challenges, for the cardiac rehab facilities throughout the nation. Currently, right now, what we're doing is we're screening the patients at least 24 hours before they come to the clinic. We confirm all visits, and we screen them. We ask them questions, COVID-related questions, if they had, any symptoms like cough, sore throat, and all that. And also, we manage the materials in the clinic. We try no physical exchange of materials like clipboards, pens, pencils, and all that. And also, we ask them to wear masks all the time. We document when a patient comes in, and we document what type of mask they're using. If they don't have any mask on, then we provide them with one. So those are some of the changes we had in place right now to make sure patient is safe every time they come in for an exercise or for a class or a session.
Excellent. And Anna, you said you provide them with a mask. What kind of mask do you give your patients?
We have the surgical mask, the same one that the hospital is providing to the patients if they need to.
Okay. Yeah. No. Excellent. And I think that's one way of doing it, which is important. It's going to come up later in our discussion. Is you are tracking who comes in with a mask, who comes without a mask, and then you make sure that if they don't have one, you give them one. Okay.
Yeah, that's right. Because if for whatever reason they tested positive, we can go back to the note and see, is this patient wearing mask? What kind of mask? To kind of make sure what kind of risk was made during that contact with that patient. Okay.
And I saw a quick question in the chat box here. How are you screening patients 24 hours in advance? Who you call them? Do you send them an email? Who calls them?
Us and also our medical office specialist. So we call them to confirm the appointment if they're coming, and at the same time, that's an opportunity for us to ask them any COVID-related questions for presence of sore throat, any member in the household who has COVID, any fever in the last 24 hours, things like that. So we confirm all visits the day before they come in for the clinic.
Good. Very interesting. Marianne, how have you changed your operations for taking in patients and screening?
So one thing that I've felt is that we've I've not felt any pressure that we need to hurry up and increase our patient volume. That may come from our leadership, but right now it's been more important to do it safely. So we've obviously limited our class size and decreased that. And one thing that we would have patients join a class time, and they still do, but we have them we give them appointment times to come. So we know who's going to come, and we're not surprised by a whole rush of, a lot of people at one time. So we'll have a window where 4 can come in, and then another 4. We've been at 3 and 3, but we're going to try to increase that to 4 and 4 so that we give time for all the screening questions and to clean all the blood pressure cuffs and stethoscopes and everything between patients to just give us, so we're not feeling rushed, and so the patients don't feel rushed and they know that we're taking care of them. We're noticing that seems to help attendance. If they have a specific time they need to come, our attendance rates are a lot higher than they were pre-COVID. Partly, I understand patients don't have as many activities going on, so they're able to keep their appointments. But one thing we're not doing that we were doing before is kind of overbooking our classes, because we would never get 100% attendance. But now we know we can't. We really need to know how many people are coming each session, so we're not surprised by a lot of people, obviously. And so that's as far as our intakes, we've been doing those over the phone as much as we can, and then finishing up those when we see them in person on their first day. But we're hoping to start those in person as well. Our staff feels that they need to see them to make a better evaluation of them getting started with us. So that will be a change that we'll implement in the next week or two. And the other thing is, pre-COVID, we would really encourage our patients to get 36 sessions, even if that took longer than 12 weeks. But knowing that we've got a lot of referrals coming in, we're probably going to have to, maybe cut them off before they get to their 36 sessions if we've got people waiting to come in. So that's an adjustment we'll have to make. And we'll add class sessions if we need to as well to accommodate more people.
Excellent.
Yeah, and
those are excellent points. Sorry, go ahead.
Jump in with a couple of questions or comments from the chat that maybe you could help to facilitate. One is a question about how frequently or how the panelists that's screening 24 hours in advance, how they're actually doing that. And then somebody made an interesting suggestion that I'd maybe get the panelists to comment on, which is whether, they're having the people that lead their rehab sessions try out what it's actually like exercising with a mask on so that they can see what their patients are experiencing.
Good. Yes. So the screening beforehand, I think Anna was very helpful. She described how we do that. They do that over the phone when they confirm that the patients are coming the next day. That's when they do the screening. I don't know if any of the other panelists has a similar experience or they do it differently.
So this is Jean Marie. We're going to do it upon entry. Obviously, we do it at the intake when I first schedule the patient, but then it may be a few days or a week later before they're starting. But I do it at the intake as they walk in, and we do a temperature check at the same time.
So you do a temperature check as well. Okay, so we're gonna have a lot of variations there. Where I think everyone does this screening before and when they come in, and then a temperature check is also going to be a variation. There will be some variation depending on whether your institution recommends that or not. And the data there is not very clear in terms of the temperature check. If you have no other signs or symptoms, if you pass the entire screening questionnaire, whether the temperature adds something or not is debatable. It's not wrong to do it, and it's probably not wrong to not do it either. Okay, Nick, how have you adjusted your classroom sessions once now after the intake and the scheduling? So now we're in the class with our patients. How are you leading those classes?
So basically what we did is we really based this all of how can we keep the patients the safest. And our solution is we actually divided our gym into basically 5 individual gyms. So we bring a patient in one at a time, station them at their gym with their own equipment, And at that point, once everyone has gotten their telemetry on and we're, all sitting there, our classroom session happens right there at their station just prior to the exercise session. So rather than having a classroom that we put them all in, we're doing it in one area. So that has really helped. And creating those patient stations has really made the patients feel much more comfortable. I will make mention that with these patient stations, originally our governor's recommendation is that a mask should be worn if you couldn't respect the 6-foot social distancing. Well, we were able to do that. Well, just yesterday evening, the new rules, because of our surge, has actually come out that no matter what, then the mask should be worn. So this is going to be interesting. We're actually going to start into a new process and see how our patients are actually affected by the mask to kind of answer someone's question as well.
Yeah, interesting. Yeah, so that's why we led into this part of the conversation, because of that question about masking. And I'm curious to hear what others are doing as well. Anna, how are you doing? I heard you say you provide a mask to everyone who doesn't have one. And then after you check them in and you get them into the gym, how have you adjusted your gym, and how are patients doing with or without their masks?
Well, we try to explain to them, the importance of wearing masks. So the situation is that basically when they're exercising and they're requested to, lower the mask, they can do so. We just need to make sure, the 6-foot distancing is observed at all times. And if they can, tolerate a certain exercise, then, they always put their mask on back, without any difficulties. Of course, we talk to them, we observe them, and just, have that open communication all the time to make sure this is something that, they can tolerate throughout the session.
Okay, very good. Yeah, so the 6 feet distancing and masking recommendations vary by location and by the rate of infections. I could tell you that here in Massachusetts, we have a similar approach that if you cannot maintain more than 6 feet, you have to wear a mask, though those are recommendations mostly for being outdoors. If you're indoors and there are people around, I think the general consensus, not necessarily recommendations, not necessarily enforced, but the general recommendation has been to wear a mask if there are people around you. It's in a confined environment, in a closed environment, that's where the risk of contamination increases. The risk is much lower if you're outside. And so allowing 6 feet of distancing and outside is much more achievable than indoors. So it'll be interesting to see how things evolve.
Yeah, and can I jump in with another question that you might pose to a few of the panelists? Somebody's asked the question about, we're having a hard time getting the referrals from the physician practices because some of the physician practices aren't open yet or are hard to get a hold of. So are any of the panelists experiencing that challenge? And if so, do they have any good suggestions for how to be addressing it?
Anyone on the panel? I think it's interesting to figure out what to do with the mask. And I lost you there for a bit, Steve. And I was reading the comments by Greg Merritt, one of our patient advocates, actually, about the masking as well.
Yeah, let me repose the question.
Yeah.
So I think the question is, we are having issues getting orders for patients interested in returning. Many of the primary care doctor offices are still operating on a limited hours, and follow-through has been an issue. Is anyone else having this issue, and if so, how are they dealing with it?
Well, it seems from our panelists that they are nearly at full capacity, actually. So I'm not sure whether that applies to their situations. Maybe someone else in the chat box can comment if they have a lack of patients. I see some of the participants actually commenting that they run in a wait list, which they never had before. And I think that's what's going to be happening, is just the throughput does not allow you to run as many patients as you used to. But to stay on this question of protection and masking. And gym reopenings, not reopening actually in the state, but having cardiac rehab reopened, I think it becomes really whether it's an essential task or not, and whether it's a medical procedure. It's not just going to exercise, it's not going for a jog outside, or going in a gym facility where you have many more people, and whether they'll be able to actually maintain the different barriers that you need to contain the virus. So frequent hand washing, everybody wearing a mask, everybody covering 6 feet of distancing, cleaning all the material and so on. So I think that's the difference between exercising in a gym versus operating in a cardiac rehab, where you have enough staffing and educated staff who will actually maintain those conditions for safety. Anything else to add there before we go on to our third question? Well, actually, let us hear from Marianne, because I heard that you are not conducting group training sessions. What are you doing during your cardiac rehab sessions then?
Well, so pre-COVID, our patients, the first 45 minutes was devoted to their cardiovascular training on individual pieces of equipment, and then we would move to a separate space. We're located in a wellness center, so we kind of travel around the wellness center, and we would be we would have everybody come together in like a gym or group exercise class room and do our strength training, do our relaxation and stretching. We felt that was going to be a little bit more high risk with just the high touch pieces of equipment with the resistance tubing that we used in the mat. So we just started simply and eliminated that part, which we hated to do because I feel like that's really important. But just with the space right now, our wellness center has not reopened because of our governor's orders to not open gyms yet. So we have it to ourselves right now, but we know that's not going to last. So we have to be careful about what spaces we take up now, and not wanting patients to be too crowded in the hallways and things. So just that, getting started simply was our goal. We've provided some home exercise guidance for them to do their strength training at home. We'll maybe teach them individually and then and encourage that at home. In their education sessions, our check-in area was also part of that with our classroom area. So we're using a bigger space now for check-in. So our classroom area is gone. So we're doing our education virtual. Well, we're sending that out through email so they have modules to get the education. So not ideal, not the way we're doing it pre-COVID, but we feel it's safer right now.
Excellent. Yeah, I think that's, again, another way of adjusting and just going with it just reminds us how fluid the situation is between the numbers that are either going up or down, and what's available to us and what's not available to us. I just want to go back to one other comment that I saw while on this topic of masking, something I saw on the chat box about how is the staff being masked. And so what are you guys doing? I have my own, not preference, but I know that there are the difference. Everybody's wearing a surgical mask. And then the question is whether you would be wearing a face shield or goggles as well when you are near patients who are exercising. And so I want to hear whether you're doing the same thing as well. Jean Marie?
Yes, we are doing, it's mandatory throughout our whole hospital. If you have any patient contact, that can be the registration person to anybody, any clinician, you're to be wearing a surgical mask and a face shield.
And a face shield. Okay, very interesting. Nick, how about you?
So it's also our hospital policy, but rather than the face shield, it's just like a disposable pair of goggles that they can utilize.
Okay, very good. And Marianne, are you wearing goggles as well or face shields?
Yeah, the first day we had the face shield, but I had the goggles coming, and the staff much preferred the goggles. So,
Yeah.
but they wear eye protection as well as the mask.
And Heidi or Anna as well? Just a quick
For
survey.
us, it's Anna. Yes, we use the surgical mask. We don't use any face shield right now. That's
Okay.
the hospital, policies, just to wear the mask.
Okay. And Heidi?
Yes, at our hospital, we are required to wear a surgical mask and either a goggle or face shield.
Okay, interesting. Yeah, so there is some data, it's not very solid, that patients who are actually exercising, they might be inclined, there might be more droplets there in that room or that area. And so because our staff is close to all these patients, there are some recommendations to eventually put goggles or face shields there. And obviously there are no clinical trials or studies that compare these patients whether wearing them versus not wearing them will increase the transmission rate. This is all based on what we suppose is correct. At the same time, we don't want our patients to feel like they're coming into a war zone and you're wearing a full gown and PPE and high protection gear because they come in to a cardiac rehab session. So there is a balance there where you want to make patients comfortable, but you want to also protect yourself. In our exercise lab, we have the exercise physiologists wearing goggles or face shields as well. Interesting. All right, so the last question I have on here on the same topic is, what are you doing to foster community and mutual support despite social distancing, or rather physical distancing, mask, and other challenges? So it is certainly challenging for our patients to be in this environment. So how are you guys coping with this and making the patients feel comfortable? So that goes along one of the principal tenets of cardiac rehab about stress reduction, but it's getting a whole different flavor in this era.
So this is Jean Marie. So we actually have a counselor that's part of our program. So she's available for individual support for patients, whether that's in person or, obviously physical distance, but also we will do virtual visits with her. For our maintenance patients, this is the real concern for them because it's going to be some time before they're going to be able to come back. I have a Facebook page that a lot of them have joined on to so they can interact with us and with other patients. And we also have a Zoom session for cardiac yoga sessions that one of our former patients teaches.
Very nice. Let me ask you this, how are you maintaining on the Facebook page, are there any HIPAA regulations or any tips you want to share with us? I'm sure a lot of programs might be interested in doing this, but it might be tricky. So what's your number 1 and 2 tips to get that? I know it's not the focus of the discussion, but I thought it was interesting.
No, absolutely. It was started by our marketing group years ago, and it's a private group, so they have to, I am the administrator for it, and they join in. So that's, how we kind of keep it secure. But also, things like we opened up, we're opening up on Monday. I took a picture of the staff, of us getting together during our meeting, just so they can see our faces and get keep connected to us. And I constantly put on actually Million Hearts education in there, just putting education, so keeping that going at the same time. So things like that we'll give to them.
Okay, and obviously nobody's sharing any private patient's information, and the patient are asked not to share their medical problems and all that. Very, very good.
Yes.
Heidi, how are you doing?
So what we decided to do is, as you guys all know, the phase 3 program, the socialization is a huge aspect of their participation. We've been allowed recently to reopen our phase 3 program. And what we did is we opened it up to all our phase 3 participants, but they are allowed to only make one appointment at a time. And we're trying to keep their appointments similar to the group that they were used to exercising with. So when they come back in, they see at least one familiar face of their former exercising group.
Okay.
And then we are just allowing them to come in for that initial appointment, and then from then they can make another appointment. So that way it's fair for all participants. But since we're only allowed to see 2 people at a class and open only 2 days a week for them, sometimes they're going 2 weeks in between appointments.
So you had classes of about 15 patients, and you're down to 2 patients only at a time.
Mm-hmm.
So did you have to adjust the hours and how many offerings do you have, or what? How have you adjusted that?
Well, we have had to adjust the hours a little bit. We are allowing 6 classes per day, but we had to work with that's also the day we do our phase 2 intakes. That's why it's limited to only 2 phase 3 patients at a time. So we can only have 3 patients in the room at once.
Okay, yeah, so interesting. So that leads us to our next topic about, now that we have fewer sessions and maybe more time in between sessions, how are you handling that with the support you're providing to patients? Maybe I'll call back on Jean Marie again.
So, I mean, the sessions, it's definitely changed to where it's, you come in, you exercise, and you leave. Same thing, we remove the resistance training, but that's where the supports like the counselor, we have a dietitian, and those things will come into play too as well. Also, educating and really getting them engaged in home exercise early on, because as we know, we don't know when the next spike or peak will come, and these things may readjust again. So we want to get them engaged in that and learning how to do exercise on their own. So if that happens, they're well equipped to do so. Okay,
very, very nice. And so are you guys still, Heidi, are you still using virtual visits and virtual rehab as well, or for patients still coming in, or you separated the 2 cohorts?
We are continuing to offer virtual services. For patients who are coming in twice a week, we have stopped calling them at home, but they can continue to do virtual sessions with our health psychologist and our dietitian. And for the higher risk patients who are only allowed to come once a week, or for patients who aren't comfortable coming back yet, we're offering virtual visits once to twice a week.
Okay, very, very nice. Nick, how you said you were in a rural area, and you're serving a very wide area there. So how have you adjusted that between the reduced offerings sessions offered and your hybrid program? How have you been doing?
So just because of limited resources, and a lot of times revenue means everything, we really didn't have an opportunity to have a hybrid program. But what we did do is employ our home health that is employed by the hospital, and we were able to utilize volunteers and then some of the nurses in that situation to really reach out to our more vulnerable patients. Our more stable patients, they were able to call us at any time and give information, but we just really didn't have the opportunity to do virtual visits.
Okay, very good. So one couple of more questions here. I know we're running short on time, and we may have spent a little more time on the initial questions, but I think they were very informative and instructive. I think one important question that we have here is, what's your plan for responding if a patient at one of your sessions later tests positive for COVID-19? So Marianne, again, maybe what's your plan in your institution?
We'll contact our infection prevention team and follow what their protocol is and what they want us to do.
Okay. And Anna in Texas, what are you handling this?
Okay, so basically we will go back and evaluate, the interaction that had happened. So our note is very important, that we need to be more detailed on, what transpired during the session. And so we evaluate whether there's a low risk or high risk exposure that occurred. And also at the same time, we follow the infection protocol set by the hospital. That is like doing deep floor cleaning, using UV light in the clinic for treatment, of course, not allowing patients to come in until everything has been cleared by the infection control committee.
And very good. Yeah, so that's why I liked your initial comments about Are you documenting whether patients are coming in with or without a mask and what type of mask? Because that allows you actually to risk stratify those patients. Heidi, how are you doing this? Are you just involved in your infection control people, or how are you doing?
We would involve, infection control. We also are able to do tracers, so we would know every patient that came in contact with that particular patient and any staff that would have. And then I also rotate my staff, so they are exposed to different areas, and hopefully if someone were to get exposed, we'd be able to fill in their spot while they quarantined.
Okay, very good. Yeah, so you have to think about the staffing as well. Nick?
So yes, our hospital policy is that we would actually start a tracer, in fact, on if someone tested positive. And then we also would offer antibody testing per our policy to anyone that was exposed. And then it's also, we would report to our State Department, and then they would start contacting folks outside of the hospital that this patient may have come in contact with.
Okay. And Jean Marie, I'd like you to comment on the last question here, please. Are you and your patients expecting a gradual return to normal, or are you preparing for a new normal? So really, it's a matter of, the crystal ball, what do you think you're going to be doing?
So, like yourself in Boston, we have experienced, the gravity of this situation. I myself was working as a safety officer on the COVID floors, so saw it firsthand. So, we know what it can do. We actually lost a maintenance patient. He hadn't come in a couple of years, but was lost to this disease within 48 hours of contracting it. So we take it very seriously. And I think it's going to be a new normal. We really have to think about, who we're bringing into a hospital setting. Is it 100% necessary for them to be there? And, how are we going to keep people safe? Because we're already hearing about other strands of other viruses that are, out there. I think this is going to be the new normal, and how do we adapt?
Yeah, I think you're absolutely right. I think in interest of time, I think the other panelists are probably expecting the same thing, that this is the new normal. I saw a quick comment there from Greg Merritt again saying, should we involve the patients in the decision to what does the new normal mean? And so should the patients be involved in those decisions and descriptions? And I think that's a very good comment. I'll move on to our next topic, which also I saw it in the chat box about staffing shortage. I know a lot of people have been either redeployed somewhere else or doing other things, and also been quarantined or isolated and or furloughed, unfortunately, in some programs. So how are you doing in terms of income and billing for virtual visits, intakes that are happening on the phone, and so on? Nick, how are you doing there?
I was actually quite fortunate in not losing any staff. We did have to take our schedule and so that we could adequately be able to do our intake and then see the maximum amount of patients. I did go from 5 days to 4 days, and then we only have 3 days of gym actually. And then that's so we could do those 8 classes. But we were able to keep that same staff, and they're at 10-hour shifts now, 4/10 versus, the 5/8.
Okay, very good. And Heidi, have you come up with anything that would allow you to maintain your staffing?
Oh, what we have, we unfortunately had to reduce our staff, and so we've had to combine a lot of roles. So what I'm doing to keep our program going and to support those virtual visits, since we don't get reimbursed for them, is just having staff multitask. So we're able to do virtual visits while we're also doing on-site patient visits, and we have an inpatient and a stress lab we have to staff. So I'm just mixing all the roles in to kind of keep the staff busy and keep us afloat.
Very good. And I think that's very important, because that's the last topic we have there is, how are you handling and helping your staff coping with the uncertainties of the jobs, of dealing with patients and their families and friends. And so as institutions and as colleagues, how are you handling this? Jean Marie, what are you offering to your staff?
So we have our counselors. So we had our first training before we open on Monday, and I offered up them to meet with her individually at any time, because I have done the roles where they've been on the floor and seen the worst of this. So I take that very seriously and want to give them all the support I can. But yeah, definitely it's going to be something that we're going to see this effect long term on people as we recover and things settle down. It's kind of sinking in for a lot of people right now. So that's definitely something I want to continue to support and do, and offer them that, that opportunity, encourage them to take vacations now and, give themselves some time to recover from everything that's happened.
Yeah, thank you. No, that's very, very important. Anna, you're in Texas, and so I'm very curious to hear how are you doing with your staff and your colleagues.
Okay, yeah. Actually, our situation right now here in South Texas, there's really increased cases of COVID right now. So as a leader, I try to attend the daily huddle meetings at the hospital and have that open communication with the staff of what's going on as a system. Them being informed is, giving them the tool. Once you communicate with them and have, that open communication, you always try to work as a team. And so we actually just try to clean the facility at the beginning and at the end of the day also. And we also have an employee assistance program that offers counseling for the staff. So that's another thing that, we explore.
Very good. So our jobs are not only important for our patients, but they are also important for our colleagues as well. So thank you all for being there. And one last information that I have here is a resource here shared by some of our colleagues from the CDC and A Million Hearts, and we'll have that in our panel. This is in regards to if one of your patients actually ends up testing positive for COVID, and you get contacted by the tracers, by the Department of Public Health tracers, what can you actually disclose? And this is the official document there, and you can, as part of medical information there, you can actually disclose the patients who were in the same class, the staff who were taking care of that patient, and so on. So that's actually allowed for this specific purpose. And that's the resource there for future references. You can download it and link to it. And we have one last audience question. And while it is there, I'd like to thank all our panelists. And this was one very, very enriching discussion. And I want to thank you for everything you're doing out there for your patients, your program, and your colleagues. And I want to thank all the other participants as well on the webinar. For their questions, for attending this. And again, it really speaks to your engagement and your interest in this field. So the question is, hybrid cardiac rehab program blends on-site cardiac rehab with activities done at home. Some CR programs are considering long-term or permanent transitions to a hybrid cardiac rehab model. How interested would you be in participating in future affinity group sessions that address using hybrid CR approaches most effectively? And you have 4 options there: very interested, somewhat interested, not interested, or not interested at all.
Yeah, thanks very much, Hisham. And please go ahead and respond to that last question. We're using that as we plan for the next event. I'm sensitive to the time, and we want to thank Hisham, all of the panelists, and all of you for participating in the event. Just to mention a couple things, the next call is tentatively set for the middle of August. But we're still finalizing the details on that. We will send you all by email within the next week the slides from today's event, as well as an event summary. And then if you have a chance, just as you're closing, there will be some pop-up feedback questions, because we want to make sure that the logistics in these events are as useful and as helpful for you as they possibly can be. So if you can fill those or just respond to those as you finish off, we would deeply appreciate it. Thank you again all for being on the call today. Thanks our panelists and to Hisham, and have an excellent rest of your day.
Thank you, everyone.